Hello and welcome to the Imedex Best of Day series as we look at events that are going on here at our annual hematology meeting. My name is Dr. Joseph Mikhael. I'm a hematologist at Mayo Clinic in Arizona, and it's my pleasure to be the chair of this series and to interview a series of experts in various areas of hematology. And it's my particular delight today to invite my friend David Steensma, who is a hematologist at Dana-Farber, who focuses in myelodysplastic syndromes and AML, to share with us some of the exciting news that is happening here at our annual hematology meeting in San Francisco. So David, welcome, and it's great to have you here.
Joe, thank you for having me. It's great to be here.
Well, it's a pleasure always to have you here, David. So, David, let's start with MDS. We'll talk a little bit about myelodysplastic syndromes, maybe transiently talk about ALL, a topic that, frankly, we never get to discuss, but as we know, there are some new developments there. And then thirdly, we'll conclude by talking about AML, acute myelogenous leukemia. But starting with MDS, you know, there's such a prolific disease, so common. Thankfully, a lot of patients don't require therapy. The standard of care, if you will, as you know, very often we treat patients with hypomethylating agents. But tell us from this meeting, is there something that we can do more than just hypomethylating? Are there better options to perhaps add something to it? I understand there were some abstracts looking at hypomethylating agents plus something else for MDS patients.
You know, we're really in a sort of fallow period with respect to drug development in MDS. The last drug approval was decitabine 8 years ago, 2006, and there's nothing really exciting in the last few years that's come along. One of the things that we'd hoped to do was improve on the existing therapies with perhaps combining therapies the way that things are done in other diseases, such as myeloma, lymphoblastic
It's about time you start
leukemia.
catching up to us in
We're
myeloma.
about 10 years behind, man. One of the studies that's being presented here as a late-breaking abstract is the US and Canadian intergroup study, S1117, which compared in higher risk MDS and CMML azacitidine alone, the current standard of care, with two combinations, azacitidine plus vorinostat, a deacetylase inhibitor that's approved for T-cell lymphomas, and azacitidine plus lenalidomide, which of course has an approval for del(5q) MDS, but for which there were phase 1, phase 2 data that suggested maybe a considerably higher response rate than you would see with azacitidine alone. So we were very excited about this study, hoping that perhaps the responses would be deeper, more durable, the CR rate would be higher. Unfortunately, the trial did not meet its endpoint. 280 some patients enrolled, and the response rates were really quite similar across the three arms, 36, 37%, whether azacitidine alone or the combination therapy. And the combinations were more toxic. Now, there was a delay in progression in the combination arms compared to the monotherapy arm, but more people came off study due to adverse events in the combination arm. So this is not going to change practice, I'm afraid.
Not even a subgroup or two, perhaps, that may have looked particularly promising with the combination?
Still looking into that, actually, to see if there's a subgroup that might benefit. I think, you know, one of the things that this trial did teach us is that people get uncomfortable in MDS patients with adverse events, with combination therapies, and are more inclined to take individuals off protocol. And that's something that we need to address as a community in future protocols. It also was not an overall survival study. It wasn't powered for survival. So it's possible that even though the response rate might not have been different, that one arm might have a better overall survival. We won't be able to tell that, unfortunately, because it wasn't a 700-patient study, which it would have had to have been.
So we're not anticipating survival data in the future. This is really the full presentation.
It'll be tracked, but I don't think we'll see a difference.
So take-home message for the clinician today is that still we use hypomethylating agents. These combinations are maybe just not what we have of what has really good advanced the field yet.
Correct. Now there are still azacitidine plus different deacetylase inhibitors that are being tried that look fairly interesting. Prasinostat at the MD Anderson combined with azacitidine. had a much higher response rate than one would have expected for an early phase trial. So perhaps there are differences with other combinations, but for right now, azacitidine monotherapy remains the standard of care for higher risk MDS and CMML.
More to come. Maybe the door isn't closed, but the door's ajar.
Shut.
Yeah. Well, what about those patients if hypomethylation remains a standard of care? Any studies looking at those hypomethylating failure patients, as it were, those patients who unfortunately progress despite or don't respond to hypomethylating agents?
Yeah. This is a group, Joe, that we really struggle with. Since there's a limited number of therapies, what do you do with a higher risk patient once decitabine or azacitidine have failed the patient? There's not a standard of care. There's a tiny subset of patients who are young enough and healthy enough to go on to stem cell transplant, and they may do relatively well, but for the others, the median survival is less than 6 months if they're treated with
And the majority,
chemo.
I suspect, are not eligible for transplant. It's a really small percentage that are eligible for
It
transplant.
is, less than 10%.
Okay.
Most get palliative care, supportive care, transfusions. Maybe they get low-dose cytarabine or switch to the other hypomethylating agent. Doesn't work typically.
Well.
So there was a trial that we had a lot of hope for, which was comparing rigosertib, which is a multi-kinase inhibitor that hits PI3 kinase and polo-like kinase 1 and some other kinases, versus clinician and patient choice of either supportive care or low-dose cytarabine. And it was a survival study. This one was powered for survival. And unfortunately, it didn't meet its endpoint either. Now, there was a trend towards more favorable survival. It was an 8-month versus about 5.5 month with the control arm. And again, there may be some subgroups that may benefit. There's an oral form of rigosertib, so this drug isn't dead yet. But this was a disappointing result for many of us in the MDS community, because this would have been the first, if it had been a positive study, the first second-line therapy. And it really is quite a well-tolerated therapy. So, it's not excessively burdensome for patients other than with the intravenous form having to get a prolonged infusion.
Well, not overly exciting then yet, unfortunately, but I do understand that there are yet a few other agents that were presented here at the annual meeting. So tell me a bit more about those, David.
Yeah, so for the lower risk patients, people for whom erythropoietin analogs are ineffective or who have a baseline EPO level that's over 500 so that we'd predict those agents to be ineffective, there haven't been very good options either. Some of them get hypomethylating agents, some get lenalidomide, whether or not they have del(5q. Non-del(5q) is an off-label indication. But there are 2 studies being presented with agents that are quite similar to one another. So sotatercept and ACE536. These are both antibodies that act as ligand traps for members of the TGF-beta superfamily. The thought is that TGF-beta signaling contributes to the anemia associated with MDS. There's some overlap with anemia of chronic inflammation. These agents are being used in other indications. They affect bone morphogenetic proteins, so they're being developed in osteoporosis. They're being developed in multiple myeloma and Castleman's disease as well. In MDS, it looks like there actually are a subset of patients who respond quite nicely to these agents. So these are both early phase studies. And so Uwe Platzbecker is presenting the ACE536, Rami Kamrochi from the Moffitt presenting the sotatercept. And the sotatercept at the highest dose level, more than 40% erythroid response rate, including transfusion independence. So I think if there's any promising agent in MDS right now, it's those 2 agents in the low risk population, which is a big unmet need. And so that's something that is a positive about this meeting. They're still quite a ways away from an approval, but this is at least an encouraging sign.
Great. So it's not all dark clouds.
Not all dark clouds.
We've got some hope there. That's excellent. And before we leave the area of MDS, I also understand that there's been some progress in diagnostics. There's always a challenge with a disease that has such heterogeneity as MDS. Yeah. Tell me a little bit about what has been discussed and what has been presented from a diagnostic standpoint.
So MDS traditionally has been a pathological diagnosis. It's relied on the presence of cytopenias plus morphologic dysplasia. The pathologist looks under the microscope and sees funny-looking red cell precursors, maybe some ring sideroblasts, maybe excess blasts, which really helps in sealing the diagnosis. But sometimes patients have cytopenias for which there's not another explanation, and yet you look under the microscope and the marrow doesn't tell you this is obviously MDS. We don't know what to do with this patient group right now because they are probably quite heterogeneous. Some of them may have other types of disorders, may have reactive causes of cytopenias. Some of them probably have true blue MDS. With the advent of genetic testing moving into the clinic, this is really, I think, helping with diagnosis, but we have to be a little bit careful about the results. So there's going to be some data presented, several oral sessions about this idiopathic cytopenias group. What happens when you do a panel of mutations that are MDS linked, looking for things like DNMT3A, SF3B1, TET2, ASXL1, the panoply of mutations that are recurrently present in MDS. And you can find these mutations in some cases. However, although many of those patients probably have MDS, we do have to take that with some caution because just this last week in the New England Journal, my close collaborator Ben Ebert and another Swedish group published data showing that in the elderly population, these mutations are present in a substantial number of people. It's a condition more than 10% of those over age 70 years going around with normal blood counts have DNMT3A or JAK2 mutations or TET2 mutations. And so, we are going to have to think about this sort of clonal hematopoiesis of indeterminate potential the same way we think about MUGUS, the same way we think about monoclonal B-cell lymphocytosis. These are precursor states for myeloid neoplasms and even for lymphoid neoplasms, but they aren't diagnostically definitive yet. And these patients probably need to be followed over time. One fascinating thing, Sid Jaiswal is going to be presenting this clonal hematopoiesis of indeterminate potential data here. These patients actually have a higher all-cause mortality as well, higher risk of stroke, higher risk of cardiovascular disease. Is it a measure of biological aging? Is it
an inflammatory pathway of some sort?
That's the other hypothesis. Yeah. Is it something to do with monocytes or platelet trafficking in these clonal hematopoiesis? Opens up a whole new line of investigation. The magnitude of risk of having clonal hematopoiesis is similar to having a high LDL cholesterol or a high blood pressure, things that are modifiable risk factors. Maybe we need to be measuring this and thinking about how we can reverse this, a field of preventive hematology, so to speak, to try to prevent these precursor conditions from developing into MDS, AML, or other full-blown disorders.
What you're saying right now is in this group that don't meet the classic features that one would expect under the microscope, for example, that maybe these genetic alterations are present, but it's hard to know if they're innocent bystanders, because this happens as we age, or are these actually contributing to the pathology of their condition.
Yeah, Joe, I compare it to a crime. It's different pieces of evidence, and some are a smoking gun. You have 10% blasts. We know what the disease is. That's myelodysplastic syndrome. But if you have a little bit of dysplasia, then maybe if you have one of these mutations as well, it's yet another piece of evidence that a bone marrow crime is being committed. But yet not definitive. You have to take the whole picture, the whole body of evidence, because otherwise you're going to put the glove on the hand and it's not going to fit.
Right, exactly, yes. How fitting that we would talk about that. So leave it to the MDS doctors to talk about crimes against the bone marrow. I hope you don't weep every time you see a ring sideroblast. So it's not really sort of ready for prime time, but I guess, as you say, it opens up a very interesting area of diagnosis. Well, let's turn our focus now to ALL. Maybe even just spend a minute or two talking about it, because there was obviously an exciting event just recently. It seems to be the week of approvals, where there was an approval for a new agent for ALL. Can you tell me a bit about that, David?
So the agent that was approved this week by the FDA for relapsed or refractory ALL is blinatumomab, which is a bispecific antibody, a BiTE antibody, a T-cell engager. One end is CD3, the other end of the antibody CD19. The goal is to sort of take the CD19 B cell that's misbehaving in lymphoblastic leukemia, bring in cytotoxic T cells in close proximity, and hopefully set up a sort of T cell versus leukemia effect. This is one of the novel and exciting therapies that are coming along for ALL. And it's great to see an approval because we need more drugs in this space. Also targeting CD19 are the SGN CD19A antibody, which is conjugated to a toxin, just the way gemtuzumab was for AML. That was a CD33 antibody. This is a CD19. And inotuzumab, which is a CD22 antibody conjugated to a toxin as well. Both of those are moving along. Inotuzumab is actually in a phase 3 study, and I'm hoping that that will be the next approval. And then the other CD19-based therapy, of course, is CAR T cells, chimeric antigen receptor T cells, bioengineered against the CD19 molecules. And so, you know, we as a leukemia community are going to have to figure out where blinatumomab is the best choice, where it's the best choice to send a patient for CAR T cells, where it's the best choice just to do another transplant after some other cytoreductive approach. But this is definitely a step forward to have a new drug available for patients with this condition.
Nice to have options for these individuals. We didn't have options for a long time. Do you think that BiTE technology that is really a kind of a fascinating mechanism that you described there in recruiting those T cells, do you think that's going to be a platform for other drugs like it to be able to follow that same modality?
I think so, Joe. I think just as with CAR T cells, CD19 isn't the only targetable molecule. And there are CAR T cells directed against, for instance, CD123 to try to clear myeloid cells out of the bone marrow before a stem cell transplant. The good thing about CD19 is that if you get rid of all the CD19 positive cells in the body, every B cell at that stage of development, you can still live because you can give a person gamma globulin infusions. If you get rid of all of other molecules, all the neutrophil precursors, you know, then that's not a good thing. But yes, I think this BiTE technology is going to be a platform for other targets in the future.
Great. Well, in our last few minutes, Dave, let's talk a little about AML.
Yeah.
You know, and sadly, there haven't been major advances in AML of late, but I do know that there was a fairly large phase 3 study here that is being presented. Tell me a bit more about that study. I think that was the one with vosaroxin. Is that how you pronounce it?
Vosaroxin, it's a unique quinolone derivative that has some effects on DNA that are unique to that particular drug. It was combined with cytarabine, and that combination was compared to cytarabine alone in relapsed refractory AML, so a difficult group to treat. 711 patients, so a big study.
That's impressive.
And unfortunately, this study did not meet its primary endpoint of overall survival, but it came pretty close. P-value 0.06. If you censored for those who went on to transplant, it did meet a survival difference. That being said, I think the magnitude of the difference, which was 7 months versus 6 months, shows that we still have a long way to go in AML therapy. So, you know, certainly we welcome things that improve outcomes, but this is a baby step. This, you know, unless we can find some particular subgroup that responds really, really well. So, yes, a positive study in a way, but remains to be seen where that drug is going to go next.
And then how about, I mean, even myself as a simple myeloma doctor, I remember the days of being on the floor and giving patients 7+3, which I understand we've been doing for 50 years now.
Yeah, we still do that, Joe.
We still do that. But there were some studies, or at least one study, I think, with sorafenib, adding that to 7+3. How did that pan out? Is that giving us hope to maybe add something to 7+3?
So the Germans did this study they called SOAR-AML, where they added to an anthracycline-cytarabine combination, which, as you said, has been the backbone of AML therapy for 4 decades now. They added sorafenib, a multi-kinase inhibitor that inhibits VEGF, it inhibits FLT3, and a few other kinases. And with the combination, there was an improvement in both event-free and relapse survival, but not overall survival. That being said, we currently use sorafenib in the clinic off-label, particularly for patients with FLT3 positive AML that have relapsed or are refractory to other therapies. In some older patients, we can use that in combination with a hypomethylating agent and spare them the intense induction and still get actually a pretty good response rate. So sorafenib is useful in the AML setting. In the SOAR AML, the benefit was seen regardless of FLT3 mutation status. So that's interesting. It suggests that FLT3 isn't the be-all and end-all of how sorafenib is working in AML, that it actually is a multi-targeted kinase, and sometimes it's good to be a messy kinase.
Yeah, of course, because you have a greater impact.
More chances to win.
Yeah, exactly. Well, before we close, I need something positive here, David. We've obviously made some step advances. We've heard a little bit about diagnostics in MDS. Clearly, an improvement in ALL with the blinatumomab being approved. But looking ahead, do you think of any other molecules? I hear through the grapevine that the IDH2 inhibitors are perhaps an area that is giving the acute leukemia doctors hope. Why don't we close by talking to me a little bit about that?
Let's finish on a high note. That really is looking like it's going to be a major advance for a subset of patients with AML and high-risk MDS too, where we do sometimes see this mutation. Isocitrate dehydrogenase, part of the citric acid cycle, mutations are present in up to about 20% of AML. The mutations can be IDH1 or IDH2. Data are being presented on inhibitors of both of those molecules at this meeting. The IDH2 really looks like the more active agent, and Eitan Stein from Sloan Kettering is going to be presenting an update of some data that he presented at the AACR meeting earlier this year. This agent is clearly active. It cytoreduces patients with IDH mutations. It has been quite well tolerated. So there's a lot of excitement around this agent right now. Potentially can be used as a bridge to transplant for patients who you just can't get the blast down. I've had several patients of my own who've been on the IDH2 mutation study who multiple rounds of conventional chemotherapy had failed, and then this drug was able to get them onto transplant. One was just admitted yesterday for a stem cell transplant. And it was such a remarkable story. The Harvard University Gazette ran this as their lead story last Monday, this guy's response. First, the fact that we're molecularly profiling routinely AML and finding these mutations very quickly. At our institution, we have a molecular panel now. We get results in 72 hours, about 90 genes.
Very quick.
And then to use this IDH2 mutation status to decide, okay, this patient fits this trial, and then have a successful result. This is really changing how we practice. So 3 and 7 is still useful, but I'm hoping we're going to be moving beyond that soon.
So for the clinician listening, it's not going to immediately change what they're doing, of course, but it's giving us a lot of hope. Of all the different molecules we've talked about in MDS and AML, it sounds like these IDH2 inhibitors are perhaps the most promising.
I think so. I think if a clinician has a patient who has an IDH2 mutation, or an IDH1 mutation, but again, IDH2 for the moment seems to be the better drug, it really behooves them to refer that patient to one of the centers where this study is ongoing, because this agent is highly active. And I think, is this going to be the next imatinib? Well, maybe not, but this is really, really an active agent, and something that in AML, where we've had so many failures, that we're really excited about.
Well, thanks, David. I want to thank you in particular for joining me today. It's been great to have you here, and thank you very much for joining us on this series of the best of the day here at our annual hematology meeting. We do have some hope, obviously, for patients with acute leukemia, which we're thankful for. We look forward to seeing you again soon as we continue our series in various aspects of hematology. Thank you for joining us.
Thank you.